Hi, I'm Shelley Hughes. I'm a Senior Product Manager and Occupational Therapist here with Pearson Clinical Assessment, and I'm delighted today to be joined by another fellow occupational therapist, Lauren Walker. And Lauren's an expert in working with ageing populations. So, Lauren, just as a starting point, can you tell me a little bit about the challenges facing our ageing populations today?
Well, I think we're all well aware that we have more older adults in this country now than ever before. And just to start by putting a bit of context around that, over 65s, not just in the UK, but globally, are the fastest growing age group. To the extent that the Office for National Statistics predicts that within the next 50 years, we'll have an additional over 8 million people over the age of 65 in this country. On the one hand, that's fantastic. I think that's a real testament to improvements in healthcare and medical science, that we have people now who are surviving illnesses and disabilities that previously would have proved fatal, and people living and living well with long-term conditions which previously would have been very life-limiting. So I think it's important to kind of give that context to explain that just because we have an older population, it's not all doom and gloom. It doesn't necessarily mean that everyone will age poorly. But there are a lot of concerns around that ageing population, and we do know that demographic experiences difficulties with long-term conditions primarily. So a large percentage of our older population will have sometimes not just one but multiple long-term conditions, and they can be both physical and mental health that are very challenging and have big implications for their independence and their well-being. We know that older adults are more likely to have falls and also to have cognitive difficulties as well. So there are a lot of challenges there for the individuals experiencing those problems, but also for us as healthcare professionals who are attempting to support them. I think another important factor within that ageing population as well is that we know a lot of older people are living alone. Yes. And over recent years, we've learned a lot about the health implications of loneliness and social isolation, to the extent that the Campaign to End Loneliness produced some research that shows that being lonely, being socially isolated, has the same risk upon early death as smoking 15 cigarettes a day. So it's not just traditional health conditions that we're thinking about here, it's also kind of the more social aspects of health and well-being that we need to consider and support people with.
Okay, wow, very, fascinating. And in terms of, some of the specifics around things like, there's a couple of things you mentioned, like mobility or cognition and things like that. Are there things that, other areas that are very much affected that, we could perhaps elaborate on a little bit? And I'm just thinking, mobility is one that springs to mind, cognition is another one that springs to mind, loneliness you've already mentioned, mental health and things like that. There's a lot of challenges that people face.
Well, we know that falls, unfortunately, are really prevalent amongst our older population, and in certain groups more so than others. So we know that people with dementia, for example, within a typical year, maybe 70 to 80% more likely to experience a fall than other people who don't have that cognitive challenge. And the risks around falls are really quite significant. And once a person has experienced a fall, there is an increased likelihood of experiencing more falls and experiencing a greater burden of illness and disability as a result of that. So I think the challenge for us as healthcare professionals and as occupational therapists is to get in there early, really, and so to identify areas of frailty or of risk that people might be experiencing, ideally before they've had an initial fall or that initial decrease in mobility. Something that I think we're very good at as occupational therapists is thinking about the person as a whole. And so thinking about their personal attributes, be that kind of physical weaknesses that might make them more predisposed to fall, or cognitive difficulties as well. So thinking about them as an individual, but also thinking about them in the context of the environments that they occupy. So from my clinical experience, I've been a housing specialist occupational therapist, so I have a long background in adapting people's homes and providing equipment for people that will help them to be safer and more productive and more independent within that environment. environment. But also, as well as thinking about the person and the home, we also think about the activities of daily living, so the occupations, as we would refer to them. So the tasks that people will complete on a day-to-day basis, and that might be something as simple as brushing your teeth and having a shower, making a cup of tea, through to productivity activities, so going to work, childcare, engaging in leisure activities and things like that as well. So it's important to consider all of those aspects when we're looking at a person's vulnerabilities and how those risks can be reduced. And that applies for mobility and also for mental health and for cognitive challenges as well.
And do you think there are things that people can do to sort of be maybe proactive about managing these things, and what sort of things can people do to prepare and maybe help these issues perhaps not be so challenging for them? What sort of things could people put in place, or can some of these things be prevented by putting in place the right provisions and support, or even self provisions and support that people can actually put in place themselves?
Absolutely, yeah. And it very much depends on the person. It very much depends on the conditions that they're experiencing, or the challenges that they're having. But the short answer is yes. There's lots that people can be doing for themselves to prevent that ill health in the first place. And if that ill health has already occurred, if they are already experiencing a disability or a challenge of some sort, there are things that they can do by themselves or with support from occupational therapists or other health professionals, which will reduce the impact. So if we take a public health approach to that, actually there are some very similar things that people can be doing which will both hopefully reduce their likelihood of having falls, but also may be beneficial in reducing the likelihood of dementia occurring or cognitive challenges happening. So we know that what is good for your heart is also good for your head. And that's things like physical activity. So obviously, if people are getting out and are being active and not necessarily engaging in sport or formal exercise, but are getting out there and are being active in some way, we know that's good for the body, it's good for the mind as well. So reduces some of those risk factors. Diet is also very important as well. So obesity and type 2 diabetes, people who are obese, there's links around that with mobility as well. I know I've certainly had clients who find mobility very, very, very difficult as a result of their size. But also with dementia, we know that there are some links between heart disease, obesity and type 2 diabetes and some types of dementia, so Alzheimer's and vascular dementia specifically. So if people can be taking better care of themselves, then they are going to reduce some of those risk factors from the outset. And obviously we know the risks around smoking and alcohol and things like that as well. So from a public health point of view, people certainly can self-manage, and I think that applies to a large percentage of the population. I think maybe where occupational therapists would come into that is supporting people to understand what they can do and give them options for that self-management. And also maybe people who do already have cognitive difficulties or have serious and enduring mental illness, or people with learning disabilities who are quite often very, very disadvantaged and some of the most vulnerable people in our communities. Occupational therapists are skilled at working with everyone to identify ways that they can engage in self-management and self-care productively.
And can I just pick up on a point there as well, just about working with other groups and other organisations, and do you have experience of working with other organisations to kind of support the individuals in the community and help with, on the public health side of things as well? But there's a lot of organisations that we as occupational therapists work with, and I think it's important that we partner up with other organisations as well. I think we've got a lot to offer as in our expertise. So, have you got any experience of things like that, partnering with other organisations?
I do. Quite unusual experience as well, perhaps. So I spent 2 years working with London Fire Brigade, supporting their community safety team with a project that they were piloting in 5 London boroughs. And that was around supporting people in the community, in their own home. So visiting people in the home environment and identifying areas of fire risk, but also identifying areas of health risk. So very much with that public health hat on. And falls risk actually was one of the specific things that we were looking at. So we had representatives of London Fire Brigade going into people's homes and talking to them about areas of risk that they may be experiencing, or that those staff members were observing in the home environment as well. And through that project, we linked in with some more formal healthcare providers. So we linked in with some falls prevention services in the boroughs that we were working in. And that was a really effective example, I think, of early intervention. So some of the people that we were working with just weren't on the radar of the health and social care system at all. You know, they rarely attended their GP, or you know, they weren't in receipt of care packages. But some people really were linked into the health system, but weren't necessarily getting everything that they needed. And there was something about being in the home and having candid conversations that enabled people to open up about their needs and to identify things that were being missed. So there was one gentleman who really sticks in my mind, who was known to be frail. He was in regular contact with his GP, and he was actually referred into our project by a social prescribing scheme. So our staff went and completed the home visit with him, and during the course of their conversation, this gentleman revealed that he had had a few falls and a few near misses, and thankfully none of them had resulted in serious injury, but they'd really knocked his confidence, and as a result of that, he was engaging less in some of the activities that he'd really enjoyed out in the community. So he's becoming quite isolated as a result, and it was impacting on his mental health as well. So we were fortunate in being able to refer him into a falls prevention service who had a very open referral criteria. So they were willing to support people, anyone really in the community who was over the age of 60, who either had experienced a fall or simply had a fear of falling, because we know the psychological impact of having a fall or concern about having a fall can be really detrimental. And so this gentleman went off to that service, and as a result he had an 8-week programme of strength and balance classes, and we know from NICE guidelines that they're found to be effective. And we checked in with him after he'd participated in that programme, and he was absolutely thrilled. He'd not had any more falls, he was a lot more confident, and he was continuing to engage in those activities which he was really passionate about. So that was a complete win for us, and I think that's a really nice example of how taking this preventative approach and this early intervention approach and working with non-traditional partners as well. And I think we're experiencing quite a sea change at the moment in the world of health and social care. We've got publications such as the NHS Long-Term Plan, which tell us that we should all be working much more closely together. So within NHS organisations, within social care, with blue light partners, but also with the voluntary sector and the charitable sector as well. And I think that's only for the good, really, because by and large we're working with the same people. If you're vulnerable in one area, you're likely to be vulnerable in another. So this joined up approach, I think, is very, very effective. It feels like it's going to increase in this country, and I think that's a fantastic thing.
Are there any other relevant examples you can think of where you've worked collaboratively or with a service user and perhaps other professionals out there and talk about some positive outcomes as well? Yeah. There's one case which really springs to mind actually from my practice as a housing occupational therapist, and a lady was referred to me who was in her 80s, had quite advanced dementia, and had been having really frequent falls as well. So she'd been seen by one of my social care colleagues who'd made recommendations for some adaptations in the lady's home, and that's the point when the case came to me. And when I went out to see her, I visited her in the home obviously, and met her son, and her son was her main carer. And I think carers are another really important piece of this puzzle, because as people age and perhaps as people become less independent and more reliant on support from others, quite often it's informal carers, so it's family members, it's friends who are fulfilling that supportive role. So we need to be mindful that we're not just supporting the person who is disabled or unwell, but we're supporting the others around them as well. And this lady is a good example of that. So her son was looking after her, and he was still of working age. I think he was in his 50s, but he'd had to give up work in order to care for his mother full time because her needs were quite significant. And this lady would have been eligible for a package of care, but her son was quite resistant to that. I think they'd had a negative experience of respite care in the
the past, and that had made him very nervous about relinquishing his mother's care and to other people. So I went in ostensibly to complete adaptations to the home, which were needed. She was at high risk of falls, and also there was quite a challenge for her son in terms of moving and handling, specifically getting her from her bedroom into the bathroom so that she could be washed. So we completed the major adaptations, and that had a positive outcome for her. It meant that her personal care could be attended to, and also that there was less of a burden on her son through that. There was a decreased risk of falling as well. But I also worked to put him in touch with some charitable organisations who support carers in the community. And as I say, this gentleman was quite resistant to receiving a formal care package, and me coming in as a representative of a local authority wasn't really going to change that. I wasn't really the right person to have that conversation with him. But I was able to put him in touch with a local charity who do a lot of work with informal carers, kind of looking at ways that they can be supported and having conversations with them about different ways that formal services or other more informal services can go in and support them and support their family members that they're caring for. So that felt like a positive outcome. And again, thinking about that person in the round and thinking about their social environment as well, and the other people involved in her care.
Yeah, absolutely. It's so important, I think, to work with all those individuals around the family, and just make sure we look at all aspects. And I think as occupational therapists, that's what we do very, very well. So we look at things very holistically. So it's the physical, it's the psychological, it's the cognitive, all those benefits, to keeping somebody as independent as possible and living life and enjoying life and doing what they want to do is very, very important. So. So in terms of the future of occupational therapy, I mean, you've kind of touched on this, and maybe I don't know if you've got any more to elaborate on this, but I think there's there's clearly, like you say, a sea change in what we're doing as occupational therapists. What do you see as doing in the future, and what do you see changing or perhaps needs to change in the future?
I think there's a huge amount of opportunity. I think the health system, by and large, is starting to talk the same language that we as occupational therapists have been talking for decades. So thinking much more holistically, thinking much more person-centred, so personalised approaches to healthcare, co-production with the patients, the clients, the service users, the people that we see on a day-to-day basis. So I think that's very exciting. I think that traditionally occupational therapists have been involved with people at times of crisis. So we tend to only really get involved when people really need specialist help, because we're a finite resource. There isn't, unfortunately, a limitless supply of occupational therapists. So we tend, quite rightly, to devote most of our time to the people who have the greatest need. And that needs to continue. There will always be people who require that specialist input, and we're experts at dealing with complexity. We're experts at thinking about people in the round and in the context of their families, their care environments as well. So that definitely needs to continue. But I think we also need to look at how we, as occupational therapists, can be applying our skills and supporting a wider percentage of the population. So there's a model that I'm very fond of, which was produced by NHS England, and it's their universal model of personalised care. And it's a very simple triangle. It's kind of an idea that's replicated in lots of different settings, but it's a very simple triangle divided into 3 sections. So the lowest section, that the largest percentage, is the universal approach. And when we're talking about healthcare, that's kind of a population-wide approach. So what can the population at large, and what can we as health professionals be doing to make sure that the maximum number of people who have quite low needs, or maybe don't have any needs at the moment, but have risk factors, how can we be helping those people to stay well and to understand what they can do to help themselves stay well? So that's the kind of the lower tier and the largest number of people. Then moving up, you've got targeted services. So that's people who maybe already do have some support needs, maybe are experiencing some challenges in their activities of daily living, you know, reduced independence, but perhaps aren't meeting the threshold for those specialist services. So I think there's things that we can do, and the things that are already happening to again support people to self-manage, but also to train up other areas of the workforce. So I'm aware of work that's happened in care homes, for example, where occupational therapists have gone in and delivered training packages to staff in care homes that makes them better equipped to support people to reduce risks around falls, to participate more actively in their own care and in their own daily living activities. So we've definitely got a role there, and I'd like to see that increase. And then at the top of the tree, you've got the specialist services, which are the smallest numbers of people but the highest amount of needs. So I think as a profession, we need to start thinking about that triangle in its entirety. So not just focusing on the really quite disabled, really quite dependent people, but thinking about how our skills can support everyone. And I really firmly believe that anyone who is experiencing difficulties with a loss of independence or, you know, a burden of illness, everyone can benefit from occupational therapy principles. That doesn't necessarily mean that they need to see an occupational therapist in the flesh.
Right. Yeah.
So it might be that we can provide people with tools to self-manage, or it might be that we can skill up other parts of the workforce to enable people to be well for longer.
Let's talk a little bit more about the role of the occupational therapist and the sort of I guess the way they might use assessment and things like that to support their practice. You know, I'm familiar your background is very much in the social care and the health and social care sector, but do you have any experience of using those sorts of tools, or any understanding perhaps of how they might be used and applied in everyday practice?
Yeah, I think that the tools that we use, so assessments, outcome measures, we have things around you know, goal setting, intervention planning. We're very fortunate. I think we're quite rich as a profession in having quite a battery of tools available to us and assessments. And I think they're really important in terms of ensuring equality of access to services and equality of provision of service for people, and to demonstrating the evidence base. I mean, we shouldn't be doing anything that we perceive could be harmful to someone, and I think making sure that we're evidence-based as far as possible is really crucial in making sure that we get the right outcomes for our patients, our clients, most importantly. But also demonstrating that what we're doing has an impact, so a personal impact, but a financial impact as well. And let's be honest, we do exist in a world where we need to show that what we're doing is cost effective, and quite rightly. There's no point in doing something if it's not going to have the best outcomes for the person, and do that in a cost-effective manner. So I think the assessments that we use are really valuable for demonstrating all of those things. So being robust in our practice. I think also enabling occupational therapists, no matter where they are in their career and no matter what setting they've practiced in, to be as effective as they can. And one of the great joys of our profession is that we can move between physical care, mental health care, learning disability, you know, older adults, paediatrics. You know, we can and we do work with everyone across a lot of settings. And we take a lot of specialist knowledge with us, which is great, but we also need to be able to move between environments. And increasingly in the current healthcare landscape, I think we're going to be expected to work across different types of settings, and maybe acute settings and community settings. And in order to be able to do that effectively, we need tools. So we need to make sure that even if we are perhaps slightly outside of our area of expertise, that we have got assessments and you know, equipment, tools, whatever you want to call them. We've got things that we can apply and we can use that we know to be safe, that we know to be effective, and we know get the job done, essentially.
Yeah, absolutely, absolutely. I mean, and as OTs, we know we all have a massive toolkit that we draw upon all the time, and just having that, I guess, like you say, that experience across all these different settings, it places us in a very good position to be able to draw and to work with collaborate with other professionals as well. You know,
very much so.
You know, we're very much, like you say, collaborating with the physiotherapy or the psychology teams and drawing all that experience and expertise together. together is a great thing.
Yeah.
Obviously, Lauren, you're very passionate about being an occupational therapist, you know, as am I as well. And I think, you know, what do you get out of it? I mean, what is, I guess, what gets you out of bed in the morning about this, and what, you know, what are the benefits and things like that to you personally for all this positive work that you do?
I think our profession is absolutely magic. I'm so proud to be an occupational therapist, and I think we're really unique within the healthcare system because we have that holistic approach, that person-centred approach, because we work across all different types of settings. I think we're very creative as well, so we're very good at problem solving, and I really like that notion of being able to kind of get my teeth into what is it that's not working for you and how can I support you to make that better. I also consider it a real privilege to be able to work with people who are experiencing real challenges, and to be kind of accepted by them as someone who can help them to achieve. And specifically because my background is in the community, being invited into people's homes and really getting an insight into how they work and what makes them tick and what life is like for them. And the rewards of, you know, kind of getting to grips with those really significant challenges that people are experiencing, and when you see that someone has improved in some way, so that there's something that you've helped them to do that has made them more independent, or has got them back to doing something that they previously really enjoyed, that they weren't able to do before, there's nothing better as far as I'm concerned. I think that's incredible, and that might be something as basic as, you know, being able to have a wash in the morning, or I remember working with one lady who was experiencing seizures, medically unexplained seizures. And this had made her terrified of doing any cooking, and cooking had been a really valued occupation for her, specifically baking, and baking with her grandchildren and for her grandchildren. And she felt that she wasn't able to do that anymore because she felt unsafe. And so I worked with her. I assessed what her needs were, what her priorities were. We did some goal setting, and the one activity that came out very clearly as being a priority for her was cooking and was baking. And so worked with her to get back to that and to reduce some of her anxiety about that, and identify safe ways for her to bake if she felt that she was on the brink of having a seizure, what she could do. And by the end of that intervention, she was baking. She was baking with her grandkids, and she brought cakes to me, which was, of course, wonderful. So things like that, they stay with me. They make it all worthwhile, being able to see people get back to doing what they want to do.
Well, Lauren, I really, really want to thank you for your time today. It's been really insightful, and just to hear your passion and your experiences, I think it's just been such an interesting and valuable conversation. So I really appreciate your time. Thank you very much.
My pleasure. Thank you for having me.